Hello, hello. Good evening to everybody. We'll just wait for 1 to 2 minutes to let everybody join in and then we'll start with OMR. Good evening, Gauri. Good evening, Kangan. Mm, mm. Good evening, Ruchira. Mm, mm. Good evening, Pinu. All right, I guess everybody has joined in. So, welcome to 2025 session, live sessions of OMR subject. Okay, I am Dr. Priyanka, your OMR guru, and we'll be starting today with the first topic of medicine, oral medicine, that is red and white lesions, and we'll proceed with ulcerative and vesicular bullous lesions if time permits today. Okay, so we'll have this OMR session to be interactive. Okay, whatever doubts you will get, ask then and there. Okay, get it clear, and after our classes, try to solve as many MCQ as you can and ask doubts. Okay, clear those doubts on that day itself. So we'll be in a good speed. Okay, so okay. So I am going to start with red and white lesions today, okay? But before going to the red and white lesions or vesicular bullous lesions or ulcerative lesions, you should know the basic primary lesions and secondary lesions because they are going to be manifested in those conditions or those diseases. Okay, so you all must know what are primary lesions, what are secondary lesions. Okay, so first of all, what is a lesion? Okay, when we talk about lesion, lesion is nothing but a visible change in the normal anatomical structures. All right, so lesion is nothing but a visible anatomical change in normal structures. All right, first of all, tell me that am I audible and visible to all of you? Am I audible and visible to all of you? So that we can proceed further smoothly. You can uh, post it in the chat box. Okay. Am I audible and visible to all of you? Yes. All right. Okay. So, lesion. What is lesion? Basically, any type of lesion, whether it is vesicular bullous, whether it is ulcerative, it is just a visible anatomical change that happens in the normal structures due to any pathological process, any pathological process. Okay, now we have two types of lesions that we are going to study. First is a primary lesion, second is a secondary lesion. Okay, as a name suggests, primary lesion will be a lesion which will manifest first. First pathological lesion to be manifested clinically. Okay, so whatever changes that occurs, okay, initially, that is a primary lesion. Okay, manifested clinically. All right. Now, what is secondary lesion? Secondary lesion is just a altered primary lesion. I'll give you an example of both. Secondary lesion is just a altered primary lesion. All right. So I have put a table wherein I have entered these names of primary lesions and secondary lesions. So please note this down. Okay. Primary lesions starts from vesicle, bulla, macule, papule, plaque, nodule, pustule. Okay. And what are secondary lesions? Ulcer, scar, crust, scales. All right. So primary lesions, starting with primary lesions, see, if I take an example of chicken pox, okay, so chicken pox first manifested by the appearance of vesicle, okay, first it manifested as a appearance of vesicle, so that will be our primary lesion in chicken pox. Okay, then this vesicle will rupture and form a ulcer. Okay, then this vesicle will rupture and forms ulcer, and then after some days it forms a crust. All right, so this is a sequence that happens in chicken pox. So the differentiation between primary and secondary, I hope you understood. Now you will understood it better when we see each of these lesions in detail. All right. Chalo. So first primary lesion that we have is a vesicle. So can you see this uh, lesion which is on the lower lip? This is nothing but a vesicle. And what is vesicle? It is a fluid filled blister. Okay, in layman terms we call it as a blister. Okay, so it is a fluid filled blister, but there is a size difference between vesicle and the bulla. Okay, so both are same fluid filled blisters only, but the size difference makes them different. Okay, so vesicle ka size is less than 1 centimeter in diameter, whereas bulla ka size is greater than 1 centimeter in diameter. All right, bulla is also nothing but fluid filled blister, just a size difference between these two. Okay, I hope you understood this. So, for example, I'll take an example of say chicken pox is there. Chicken pox may you will see vesicles. We have example of herpes labialis. Herpes labialis. Here also you can see this vesicles. Okay. Then bulla. Bulla ka example is pemphigoid. Bullous pemphigoid. Okay. These diseases we are going to see it in detail, but just for your understanding, please note this down. Afterwards, you will understand the whole concept of it. Okay. So both vesicle bulla understood, fluid filled blister, just the size difference. Okay. Now, next, next primary lesion that we have is a pustule. Okay. Next primary lesion that we have is a pustule. Okay. So in pustule, what happens is now same example of chicken pox we'll take. Chicken pox, first there is a appearance of vesicle, but afterwards what happens is this fluid field gets converted into pus. So pustule is nothing but a fluid filled blister with a purulent pus. Okay, fluid filled blister with a purulent pus. Okay, so this fluid, the clear fluid gets converted into this pus, okay, in chicken pox, so that becomes a pustule. Okay, so just the difference of fluid in the pustule and the vesicle. Okay, so fluid filled blister uh, with the purulent pus is a pustule. The name itself suggests pus. Okay, this is our third lesion. Then we have papule. Then we have papule. Now there is a difference between papule and plaque. We have papule and we have plaque. Okay, now here also we have the size difference. So both are solid lesions, okay, elevated lesions, solid elevated lesions, but papule is less than 1 centimeter in size. Papule is less than 1 centimeter in size, okay, and plaque is also a solid lesion. This is also elevated lesion, elevated from the surface. Okay, elevated lesion, but it is greater than 1 centimeter in size. Okay, so can you just see in this picture? You can see this small white raised papules. Okay, characteristic feature of lichen planus. Characteristic feature of lichen planus. So papille, you see it in the lichen planus. Okay, then we have plaque. Plaque is also a solid lesion, elevated lesion. Okay, but the size difference is there. And plaque, you see it in the leukoplakia. Leukoplakia. Okay, plaque, you see it in the leukoplakia. All right. Moving on to the next primary lesion, which is a macule. Okay, now can you see this macule is just a flat area of altered coloration. Flat area of altered coloration. Just a color change has taken place here on the lower lip. Macule is just a flat area of altered coloration. Okay, and the example of it is melanotic macule. Melanotic macule. This we are going to see it in the oral pigmentation chapter. Okay, so macule will be just a flat area with altered coloration. All right, moving on to the next lesions. So these lesions, the cause of it is the extravasation of blood. Cause of it is extravasation of blood. All right, so we have two lesions here. First is petechiae. First is petechiae. Second is ecchymosis. Ecchymosis. The cause of both are same. Okay, but there is a size difference here. Petechiae will be 1 to 2 mm pinhead sized. Pinhead sized. All right. And ecchymosis is just a larger area of discoloration. Can you see this? Can you see periorbital as well as subconjunctival ecchymosis? So ecchymosis is just a larger area of discoloration. And what is the cause of discoloration? Extravasation of blood. All right. These are also important lesions that you should know. Can anybody, and these lesions have particular significance. Okay. So that is why we are studying this. Can anybody tell me periorbital ecchymosis of or subconjunctival ecchymosis can be seen in which cases? Can be seen in which cases? Why I'm telling you the significance of this, because you can diagnose the case by just looking at the lesions. Okay, or at least give your differential diagnosis what it can be. Okay, so can anybody tell me ecchymosis, where you see this subconjunctival or periorbital ecchymosis? If you know the answer, you can post it in the chat box. Okay. Mm. Yes, not exactly leaf fracture, but you can see it in fracture, zygomatic arch fracture also. You can see it in the orbital fracture also. So basically, fracture cases may you can see that. Yes, very good. Okay, so I hope this is clear. All right. Then we have one more lesion, which is erosion. Which is erosion. Yes, very good, everyone. So erosion is nothing but a just a shallow defect in the mucosa. Just a shallow defect. Shallow defect in the mucosa. Okay, and this shallow defect has occurred due to loss of epithelium. This shallow defect is occurred due to loss of epithelium. ठीक है? So erosion occurs in erosive lichen planus. Erosive lichen planus. All right. Erosion is a primary lesion which is just a shallow effect due to loss of epithelia or epithelial coverage. All right. Coming on to the next primary lesion, which is a nodule. Now, nodule, as you can see, well circumscribed, right? Well circumscribed, and it is projecting from the surface, right? It is projecting from the surface. Projecting from the surface. So nodule is a primary lesion that we see in a fibroma cases. Fibroma. Okay, we are going to see what is fibroma and everything in coming classes. All right, so these all are primary lesions. Moving on to the secondary lesions. Secondary lesions are right. So starting from the most important secondary lesion for us, which is ulcer, the most important. So ulcer, you all have studied in general medicine, you all have studied in surgery also, right? So ulcer is nothing but a breach in continuity of skin or any mucous membrane, right? With a necrosis of the tissue, with necrosis or molecular death of tissue. All right, so ulcer is just a breach in continuity. Ulcer is a secondary lesion that you see in, if we can say, in herpes labialis. Then we can see it in the pemphigus. We can see it in the pemphigoid. Okay, so ulcer, widely used term, and the lesion, you see it in many of the conditions that we are going to study. Okay, so ulcer is just a breach in continuity of skin or mucous membrane with a necrosis or molecular death of the tissue. All right, ulcer was easy. Next we have, this is nothing but a crust. This is nothing but a crust. Crust, crust, as the name suggests, the term suggests, it just a dried exudate of skin, right? Can you see here the yellow part, which is a dried exudate of skin, and we see it in the herpes labialis. We see it in the herpes labialis. All right, this is a crust lesion. Next lesion that we have, this is nothing but a scales. Scales. All right. Scales are nothing but a flakes of conified skin layer, means flakes of the superficial, supermost layer of the epithelium. So, flakes of conified skin layer. Okay. And we see scales in which condition? Psoriasis. We see scales in the psoriasis. Psoriasis is again an autoimmune condition. Okay. And one sign, one positive sign is associated with these scales. Okay. So that we'll study later, but just to give you a basic idea about it, these are scales, right? This white portion which you see, these are scales. Now when you rub on these scales, okay, try to remove those scales, that surface will leave bleeding points. Bleeding points when you try to remove those scales, it leaves bleeding points. Okay. And that is a characteristic feature that you see in psoriasis, and that is called as Auspitz sign, which is called as Auspitz sign. Okay. So Auspitz sign is positive in psoriasis. Okay. This is a character, we can say a takeaway from this topic. Okay. So please uh, start writing down important takeaways. Okay. So that when you just read those takeaways, you will be summarizing whole of the subject. Okay. So I'll be telling you the important takeaways from each topics. Okay. Please write it down. Those will help you in solving clinical based questions also. Okay. So takeaway from this is Auspitz sign positive in psoriasis. All right. I'll be asking it when we study about psoriasis. So please remember. Okay. All right. So next secondary lesion that we have, and the last one, which is called as scar. Scar, we all know scar. What is scar? What happens exactly in scar is a excess collagen production after surgical healing, right? When a person undergoes any surgery, incision ka area, you will see this scar formation. Okay. So scar is also a secondary lesion. What exactly happens? Excessive collagen formation at the site of surgical incision, right? So this is a scar. And these all are primary and secondary lesions. Yes. So these secondary lesions are not given separately in the notes. You can add those. Okay. Just 3 points, additional 3 points: scar, crust, and the scales. Okay. So I'll be giving many newly added points which are not given in the notes. Okay. So you can get uh, write it down in your notes itself. All right. Okay. Now, as we have completed primary and secondary lesions, I am going to start with the red and white lesions. All right. Okay. Red and white lesions. So, why we are calling these conditions or lesions as red and white? Okay. So, what is the color of normal mucosa? What do you think is the color of normal mucosa? Normal oral mucosa is translucent pink in color, right? Translucent pink in color. Now, when there is a red or white lesions appearing on the same. What exactly happens? Why it gets convert into white or red color? Okay, so first reason, first reason, first reason for change in the color is thickness, thickness of epithelium. Thickness of epithelium changes, that is increased in the thickness of epithelium, makes mucosa white in color. Okay, second reason why it gets converted into white is amount of vascularity, amount of vascularity. Okay, so vascularity will make the mucosa little pinkish red in color, right? But change in the vascularity will make mucosa white. Okay, so if there is a decreased vascularity under the mucosa, it will make mucosa white. Now, in which all conditions this amount of vascularity changes, that we are going to see. All right, in which condition thickness of epithelium changes, we are going to see that. Okay, the third reason that we have is a degree of keratinization, degree of keratinization. Okay, keratinization increases, increase in keratinization process, okay, makes mucosa white in color. Then we have next reason, formation of pseudomembrane, formation of pseudomembrane makes the mucosa white. Okay, so pseudomembrane will be a one more extra additional layer on the epithelium, right? So this makes mucosa white, right? Then fifth reason and the last reason is the pigmentation, pigmentation, pigmentation. So change in the pigmentation, increase melanin synthesis, increase melanocytes will make the or will change the color of the mucosa. Okay, so normal mucosa is translucent pink, and the reasons for changing its color might be these five, right? So this is for white color. Now, why this mucosa becomes red? So there can be a atrophy, atrophy of epithelium, atrophy of epithelium can make mucosa red, or there can be dilatation of blood vessels. Okay, so these are two reasons why mucosa can change to red color. All right, so these are reasons for white and red color. Now I am going to start with the I can say the I have divided or classified the lesions into groups. So starting with first, we are going to see normal variation of mucosa, normal variation. Okay, there is no benign process involved, there is no malignant process involved. Okay, so normal variation, then we are going to see about post-inflammatory lesion, post-inflammatory. Okay, then we are going to see pre-malignant, pre-malignant lesions and conditions. Okay, and lastly, we are going to see white lesions with no malignant potential, no increased malignant potential. Okay, so in normal variation we are going to see about leukoedema, linea alba, and Fordyce's granules. So these three are normal variation of mucosa, and expect one or two questions from this. Okay, normal variation. Then post inflammatory lesions, fact about pre-malignant lesions and conditions I'm going to tell you. Okay, so past many years, we are calling it as a pre-malignant lesions and conditions separately. Okay, but this, what this implies, what this pre-malignant, what this pre-malignant, the prefix pre-malignant implies that every lesions and conditions are going to convert into cancer, right? That what it means, pre-malignant lesions and condition. So what WHO has done in 2005, year 2005, very very important point, mark it, star mark. Okay, so in 2005 WHO has renamed all of these lesions and conditions into one, or grouped under one term. Which is that term? Potentially malignant disorder. Potentially malignant disorders. We no longer call pre-malignant lesions and pre-malignant conditions separately. So they have put all of these conditions under one term, that is potentially malignant disorder. This was one of the MCQ in, I think, 2024 NEET. Okay, so potentially malignant disorders is the term that WHO has given. Okay, but uh, I have put up this I have put up this table. This is from Ongal. Okay, this is from Ongal, and we have still pre-malignant lesions and pre-malignant conditions that they have given. So just go through it once. Okay, uh, you should know that these were the pre-malignant conditions and lesions. Okay, now we are calling everything as a potentially malignant disorders only, right? But just for your reference, that previously it was like this. So just go through this table, and yeah, all right. So starting with this table, so these this table consists of non-scrapable and scrapable lesions. Okay, non-scrapable and scrapable lesions, very important. They can put this under clinical based question. Scrapable lesions, they'll give you four options. You have to mark which is the scrapable lesion among four, right? So you should be thorough with this at least. Scrapable lesions, right? So chemical burn or thermal burn, pseudomembranous candidiasis, syphilitic mucus patch, and diphtheric patch. These all are the scrapable lesions. Scrapable means just you can just scrape it off the superficial layer of the lesion easily. Okay, you can just scrape it off superficial layer easily. That is why it is called as scrapable lesions, right? You can make a mnemonic and everything, and you can just remember these scrapable lesion. Okay, and non-scrapable lesions are this. You cannot scrape it off. You cannot scrape it off the superficial layer of these lesions. Okay, so okay, this you have it in your notes, so no need to write it down. Okay. All right. So please remember these scrapable lesions. I'm going to ask whenever we are going to learn about these conditions. Okay. Moving on further, the first normal variation that we are going to see is this. This is nothing but a leukoedema. This is nothing but a leukoedema. Okay. Leukoedema, can you see this grayish translucent? Here there is a translucent wrinkled surface, right? So leukoedema is a translucent grayish or white, you can say grayish or white translucent lesion, right? The wrinkled appearance is wrinkled or folded. Can you see this wrinkled appearance and folded appearance, right? Now, what is the importance or significance of this leukoedema? Okay, what is the significance of leukoedema? On stretching, on stretching, the lesion disappears. On stretching, lesion disappears. This is your takeaway from leukoedema. Very important. Directly, they can ask direct question from this. On stretching, this lesion disappears. Now, what is histopathology behind this leukoedema? Histopathology behind this. So, histopathology behind this is there is abnormal thickening of the spinous layer. Okay, there is intracellular edema. So, there is a abnormal thickening of spinous layer, and there is a intracellular edema. Okay, so this makes intracellular edema means fluid retention. So I'll give you a basic example. If in the balloon you fill up the water, okay, how this balloon becomes, how the balloon swells up, right? Balloon swells up when we fill water inside it, and how the color changes of it, it becomes more translucent, right? So the same mechanism applies over here when the cell is filled with the fluid. Since there is a edema, there is a fluid retention. Okay, the cells swells up. Okay, and the color becomes translucent, and this uh, stretching, on stretching, it disappears. So when you stretch the mucosa, the lesion disappears. So because the fluid settles down. Okay, so this is a histopath behind leukoedema, and the important point in that. Okay, I hope this is clear. Everybody with me? Everybody with me? Understood everything? Let's move on to the next lesion, which is Fordyce granules. Fordyce granules. Everybody with me? I want active participation of all. Huh? Yes, okay. All right. So next is Fordyce's granules. Fordyce's granules are nothing but what? Ectopic sebaceous glands. Ectopic sebaceous glands. Right? Ectopic sebaceous glands. Why ectopic? Because unusual site. Sebaceous glands are not supposed to be in the oral mucosa, right? But they are there. So we call it as a ectopic sebaceous glands. And these are like a white to yellowish spots. These are like white to yellowish spots, right? White to yellowish spots, and patient uh, will not be aware of it sometimes, and some patients are aware of it, so they tell you, yeah, these are some abnormal color change or spot seen in my buccal or cheek, right? So patient, many of patient will not have this anything, any pain or any burning sensation, nothing at all. But some patient will just notice it. They'll not have pain or burning sensation, but they'll just notice it. Okay, and they'll tell you what is this, what is. So you have to counsel the patient. It is not the harmful or dangerous condition. It is just a normal variation. Okay, and if patients have aesthetic concern, then they can undergo this laser therapy. Okay, so laser say they can get it removed if there is a aesthetic concern. Otherwise, there is no need for the treatment. Okay. Uh, all right. So these are fordyces granules. Very important. Can be asked. Fordyces granule mainly they'll ask about ectopic sebaceous glands. Okay, ectopic sebaceous glands. All right. Moving on to the next. All right. Moving on to the next and most common normal variation, which is a linea alba. Which is a linea alba. Many of you must be having at least Fordyceps granules or linea alba or leukoedema, right? It is just a normal variation. So this is a linea alba. What is this? This is just a white keratotic line. Can you see this white keratotic line? This is white keratotic line seen along the occlusal plane. Seen along the occlusal plane. Okay. Or parallel to the occlusal plane. Right. So when a patient bites, okay. So due to chronic duration, what happens is there is a friction between the buccal surfaces of tooth and the buccal mucosa, right? Buccal surfaces of teeth and the buccal mucosa. So, due to continuous friction, what happens is there is an increased keratinization that take place, and that leads to linea alba. Okay, so there is no malignant process attached to it. This is just a normal variation. There is no harm, nothing will happen. It just will be there for lifetime. Okay, so due to continuous friction, this occurs, linea alba. Okay, now next we are going to be starting with the post inflammatory lesions. Okay, so post inflammatory lesions may we have first we have traumatic keratosis or frictional keratosis. Traumatic keratosis or frictional keratosis. Now, I'll show you one image in which can you see this? Can you see this? Can you appreciate this keratinization that has occurred over here? Keratinization that has occurred over here. And you will see this in many patients with impacted third molars, right? Impacted third molars. If you notice the mucosa around that impacted third molar, you will notice this increased keratinization, right? This is nothing but traumatic keratosis or frictional keratosis. This is due to continuous friction, the same mechanism that has occurred in the linea alba, right? This is due to continuous friction between the tooth and the mucosa. This occurs. Okay, and the most common causes for frictional or traumatic keratosis is sharp tooth, sharp tooth, or broken tooth like a root stump. Okay, root stump if patient have. Okay, and it is not as sharp as to cause a ulcer, but it causes this traumatic keratosis, increased keratinization. Okay, so broken tooth, sharp tooth, or rough edge of denture can also cause this traumatic keratosis or frictional keratosis. Okay, from today itself, if you are an intern, start noticing these lesions in the patients. Okay, we most of the time we ignore this basic lesions in the mouth unless patient tells you that this is there, this pain is there or burning is there. Okay, so start noticing. Even if a patient is complaining of tooth pain, start noticing all the surrounding mucosa. You will definitely see some or the other lesions. All right. Okay. So traumatic keratosis or frictional keratosis, clear. Next we have this. Okay, this is nothing but this is nothing but cheek biting. Okay, many of us or many of the patient have this habit of cheek biting or lip biting, right? This is due to a mechanical trauma. Continuous trauma to the mucosa can cause this. This is called as cheek biting, or the important term that we have is the morsicatio. Morsicatio buccorum. Morsicatio buccorum is the synonym for cheek biting, which is very important takeaway from this. Okay, Morsicatio buccorum, and you will see this poorly outlined epithelium on the cheek. Poorly outlined epithelium. Poorly outlined epithelium. Okay, which is loosely attached. Loosely attached. Okay, so this is nothing but cheek biting, and due to continuous trauma to the mucosa, this changes occurs. All right, moving on to the next condition, which is, yeah, this is nothing but a thermal burn. Thermal burn, right? Thermal burn, as the name suggests, how this will manifest when you have high tea, high coffee, or hot tea, hot coffee, or you can say hot pizza bite, right? The hot cheese can cause this thermal burn. So, hot food, beverages is the cause or the reason for thermal burn. Also, when you do root canal procedures, uh, now that we have advanced technologies, but still some clinics are using this hot burnisher for condensing the GP, right? Gataparcha. So, hot instrument accidentally, what happens during the procedure, it touches the mucosa, right? So, it can also cause a thermal burn. So, hot instrument during root canal procedure can cause thermal burn, right? So you can see this thermal burn in the palatal region or the mucosa adjacent to the um, root canal treated tooth. Okay, so these are some reasons for thermal burn. So you can see the erythema, right? Erythematous area, sometimes it can cause ulcer also. Okay, so that is how this thermal burn occurs. Next thing that we have is the chemical burn. Chemical burn. Okay, next thing that we have, reverse smoking causes thermal burn. Reverse smoking causes, we are going to see smoker's palate. Okay, smoker's palate. Unless this touches the mucosa, the hot part touches the mucosa, we have the other condition, which is smoker's palate. Okay, reverse smoking can cause thermal burn. Yes, your answer for this question is yes. It can cause if the point, the hot point touches the mucosa. Yes, methylation. Okay, now chemical burn. Chemical burn means what? Due to any chemical, there is a lesion that occurs. This white lesion that occurs. That is a chemical burn. So, which chemical? Aspirin. Aspirin burn. If due to aspirin there is a chemical burn happened, then it is called as aspirin burn. So, how this aspirin burn happens? Uh, some patients, when they have tooth pain, okay, they powder the aspirin tablet and they apply it over the mucosa. thinking that the tooth pain will subside. Okay, in that cases, you will see this aspirin burn. If you ask history to the patient, they will tell you this is a history. Okay, they have applied this aspirin powder or something like that in that area that has caused this aspirin burn, right? Another example, there is a wide, you can say, practice of applying clove oil for tooth pain. Okay, this can also cause chemical burn, aspirin and clove oil. So these two can also cause this chemical burn. All right. Okay. Now moving on to the next. I hope everything is clear up to now. I hope everything is clear. Now we are going to start with the most important lesions, most important for your exams, and as well as in your clinical practice, most important lesions that you should know. All right. So starting with the first important lesion, that is leukoplakia. Leukoplakia. Now leukoplakia ka definition is, it is a white plaque or patch. Okay. It is nothing but a white plaque or patch. Okay. That cannot be characterized clinically or pathologically. Okay. So it is a white plaque that cannot be characterized clinically or pathologically as any other disease or condition. Okay. And is not associated with any physical or chemical agent except from the use of tobacco. What this definition tells you, that leukoplakia is equal to tobacco. The cause of leukoplakia is tobacco. If a non-tobacco chewer or non-tobacco smoker will show the leukoplakic lesion, that will be more suspicious for malignancy than tobacco chewer. Uh, you can say the lesions that you see in the tobacco chewer patients. Okay, so I'll tell you which points are important when you see patients who is not eating tobacco or chewing tobacco or smoking tobacco shows these kind of lesions, what it means. Okay, so leukoplakia is white plaque or patch that cannot be characterized clinically or pathologically as any other lesion and is not associated with any physical or chemical agents. ठीक है, except the use of tobacco. Okay, so leukoplakia will be associated with tobacco. Causes of leukoplekia can be tobacco, alcohol. Now alcohol will not directly cause leukoplakia, but alcohol will synergize with the tobacco and make the effects of tobacco more, you can say, harmful. So alcohol and tobacco both work together and make this happen. Okay, so alcohol alone will not cause leukoplakia, but it will help tobacco in causing the leukoplakia. All right. So how this alcohol will help tobacco? How this alcohol will help tobacco? Now alcohol, what it does is it dehydrates the mucosa. Alcohol dehydrates the mucosa, making the mucosa more permeable for tobacco products to enter into epithelium. Okay, so alcohol dehydrates and make the tobacco products more permeable inside the mucosa, and they'll enter the mucosa, and then the effects will start happening, right? So this is how tobacco and alcohol works together. Then the next cause can be HPV, human papilloma virus. Okay, HPV also can cause leukoplakia. Okay, so you can say I am going to tell you how this causes will be manifested, okay, and how will it occur, how will we see after HPV infection, okay, and everything. So leukoplakia, all right. Now leukoplakia, we have divided this leukoplakia into two types. Into two types. First is homogeneous. First is homogeneous. Second is heterogeneous. Okay. So homogeneous leukoplakia will have a white component. Will have a white component. Heterogeneous leukoplakia will have both white as well as red. So white plus red component. Okay. Now, in homogeneous leukoplakia, can you just appreciate here this? This is a white plaque. Okay. Plaque we have seen. It is a solid lesion and size is greater than 1 centimeter, right? So it is a solid elevated lesion greater than 1 centimeter in size. This is a plaque. So plaque here, white plaque, okay, and the appearance of it is wrinkled. Can you see the wrinkled appearance? Wrinkled appearance, okay. Then the texture will be smooth to leathery. Texture means when you touch the lesion, smooth to leathery. Okay, smooth to leathery appear texture is there of leukoplakia. Then the most important takeaway point is it has got cracked mud appearance. Cracked mud appearance. Okay, cracked mud appearance is our takeaway point. Homogeneous leukoplakia have got cracked mud appearance. Can you see these cracks are there? Fissures are there inside this lesion. There is a cracked mud appearance, we call it as. Common sites in which you see this leukoplakia is buccal mucosa, ventral tongue, floor of mouth. Okay. Now, most of the patient will not complain of any pain or burning sensation. There is no pain or burning sensation, okay, unless it is super infected with a candida. Candida is what? Fungal infection, candidiasis. Okay, so when the leukoplakic lesion is super infected with the candida, patient will have a burning sensation. Okay, so please write it down. If super infected with candida, patient will have burning sensation. All right. And our treatment will follow according to the symptoms. Our treatment will follow according to symptoms. Okay. So just all right. So we'll be taking a break now, and we'll start with this leukoplakia, the treatment part, in the next session. All right. Is that okay with you all? We'll be taking break and we'll meet after a break. Okay. And you have to, I think, log in the app. Okay. Okay. So take a break of 10 minutes and we'll see you there. All right. Just a 10 to 15 minutes. 10 minutes. We'll meet at 7:15. All right.